Hopefully that's all fine. Thanks very much for the invite. So my name is Chaloner Chute. I'm the Chief Technology Officer with DHI. We are an innovation centre based in Scotland in the UK. And our job is to work with the NHS and industry and academia to transform health and care services using digital. So just a little bit from us. We as an innovation centre in Scotland have a twin role of developing digital health and care services and transforming the way we deliver services, but also in stimulating economic growth. So we do things in a way that will stimulate the local business base to allow them to learn and export effectively. And on the right hand side, you'll see that kind of diagram very loosely describes our innovation model, which is around service, technical and commercial innovation. So we don't just look at technologies, we look at the way services change, we look at the way technologies work with those, and we look at sustainable commercial models so that these digital services can be viable in the marketplace. I'll just give you a little bit on our background before I get into the COVID piece. A lot of our work is predicated on what is effectively the emerging fourth industrial revolution, the Internet of Things, the Internet of Services, the Internet of Everything, and we are seeing the proliferation of Industry 4.0 in manufacturing, but also Health 4.0, smart hospitals and new ways of connecting the full value chain of healthcare and medical care, and optimizing that care using Internet of Things and broader internet technologies. And the bit we're particularly interested in Scotland and as DHI is the one on the right hand there, which is Care 4.0, which is around using all the same technologies to allow citizens to be proactive, active members of a co-managed care team. So we're interested in empowerment, personalization, and flexibility from these sorts of technologies that will allow us to better understand someone's whole life, so that our healthcare, interventions are better aimed. We do that, and a lot of our work is around systems integration and the art of the possible, and proving to people that we can create these integrated data sharing systems that will support that kind of co-managed model. So I won't go into the details of this, but we innovate around data exchange infrastructure, and ways that we can combine people's personal data, consumer data, algorithmic outputs, medical devices, core clinical record systems and electronic health records, and kind of care management and social care kind of tools. And so this is just a very simple example of some of our very initial work, some of our proof of concept around how a citizen can manage the flow of their data and allow it to be shared between agencies and sectors through consent-based, GDPR compliant kind of models. So that's our kind of day job. I'm just putting that out there just so you understand where we were at the start of COVID, and that obviously has a bearing on our work. An example of that that thing in action is we've got NHS Greater Glasgow and Clyde, which is a 1.2 billion pound a year turnover health board, so largest in the UK, running a COPD remote monitoring service using this sort of methodology. And what that means is they have connected their medical devices, so home ventilators and respiratory kind of tools. The citizen is allowed to connect their Fitbit or wearable or smartphone, and through a combination of the physical activity and sleep monitoring that the citizen can provide for themselves using their own technology, and the medical devices provided by NHS for respiratory rate and home ventilation, we are able to then through that data exchange offer a respiratory team a proactive dashboard powered by machine learning that risk scores people proactively, and stratifies their risk of hospitalization and morbidity, and allows them to effectively identify the trends leading to an exacerbation earlier. So that's an example of that kind of co-managed piece that allows preventative and personalized care. So for COVID, we were in a position where we had a network, a set of infrastructure, and a methodology of rapid innovation that allowed us to move quicker than anyone else in the UK, and start deploying these sorts of services to support the COVID effort. I'm not going to go into the fine detail of these diagrams, but these are the initial high-level architectures that we proposed to Scottish Government at the outset that effectively said, using World Health Organization guidelines, we can think of our whole healthcare system as a structured data collection exercise against a standard for the purposes of surveillance and outbreak management. So instead of trying to create an entirely separate infrastructure and methodology, public health should be conducted through the act of normal clinical care and normal interactions with people. So on the left-hand side, this is us saying, this is us saying, can we get all the lab result systems integrated into one place? Can we pass the COVID test results as they come through into that data exchange that we spoke about? And through that, can people access their own test results? When they access their own test results, they will obviously get phoned up by contact tracers as per the normal model. We can offer a contact tracing dashboard for contact tracers based on that single source of test results nationally, and that will allow them web forms and case assignment type functionality as you'd expect in any contact tracing system. But more importantly, can we allow the person on receipt of their positive result to start submitting their own contact tracing records? So the idea being that they are co-managing their contact tracing record. So the minute they have their positive, they could be starting to go through their diary, figuring out who they've met, and start curating their list of contacts and pulling together contact details, so that when a contact tracer gets in touch, it's a much more productive conversation. The person's ready. They had an opportunity to do a bit of the detective work themselves. Now, obviously, not everyone's going to do this, but the idea being is if 30 or 40% of your population are digitally active and enabled and motivated, that could relieve some pressure on the main contact tracing approach. And then we're not in this phase yet, because we're not doing active surveillance, because obviously the volume of what's going on. But the idea then being that through the same co-managed digital relationship, we might be able to automatically cascade to their contacts daily check-in or symptom checker or other functionality that would allow us to kind of crowdsource intelligence around symptomology across contacts, etc. So we haven't put that last bit live, but we've prototyped it, and we're ready to. But that's probably more of a thing once we have things better under control and the volume is lower. And so that's more of the kind of public facing side, and I'll drill down into those in a minute. On the right hand side here, you're seeing how we empowered some of the routine clinical care professionals through this. So again, we have a single integrator for our medical record systems. We have a data exchange, cloud-based modern data exchange, and what we effectively did was created a clinical assessment tool, which is an SBAR, situation, background, assessment, recommendation. So a clinical assessment and review tool, and based on World Health Organization guidance around COVID, we coded that up, and we agreed at 80% record, so 80% across all use cases are using the same basic record structure, and that was for assessment centers, which are specially set up for COVID people presenting with COVID symptoms who are not ill enough to go to hospital but too ill to stay at home, for emergency departments and for ward rounds, and for care and nursing homes. And each of those settings has 20% variance. So they each have their own specific needs. So for example, care homes, we have decision support rules that calculate news scores and other kind of things based on observations, which obviously isn't as needed in the more medical settings. And so the idea there is that across primary, secondary, specialist, ambulance, and care home care settings, we get the same structured data collection of people presenting with COVID symptoms. That all feeds in to the data exchange. The safe haven is a version of all that goes in there for research purposes. So we've got long COVID studies and various other things, keying off that safe haven. But then it also feeds into the electronic health record integrator and feeds the outcomes or data from these into secondary care systems, hospital systems, primary care systems, GP records, and then into the surveillance team, the public health surveillance team, and into the national contact tracing system. So that's a kind of very kind of quick, high-level overview of the kind of architecture. So I'll just quickly go into some, a little bit more of the detail of each of those. So this is what we call the National Notification Service. So this is that single national approach to delivering test results on an automated basis. Creating that single national feed of results by integrating many different lab systems. We send out, we didn't want to create a login or a registration thing for patients. We wanted it to be as low barrier as possible. And we don't have a national ID card or equivalent in our country. So there is no easy way of allowing someone to sort of log in or register for us. Nor did we want one, because we wanted this to be low barrier. We wanted a lot of people to very easily and quickly be able to use it. So instead, what we did is we associate a unique number, an NHS number, with each citizen. When they get their test taken, the test is accompanied by that number. This system then sends out a unique web link in a SMS or email that's uniquely associated with their number. They then click on the link, are asked for surname and date of birth validation, and then that, with the token that's in the unique URL, allows us to link it to their patient record, and then they can see their result. So it's not as strong an identity binding as we would like. We'd want them to have an account and register, etc. But this is the easiest and quickest way of getting it across the whole population. Importantly, in this method, it's not just putting the test result inside the body of a text message. We get a read receipt. We know when they viewed their result, which is very important for our clinicians to be able to let go of the responsibility. But normally in the UK, the person who takes the test or orders the test is ethically responsible for delivering the result. So this was the way that we managed to satisfy our medical community to say we know when someone has seen their result, and we know if the right person has seen their result. And then the people who aren't self-serving, you can then treat with phone calls and other mediums as you normally would. And through doing this, we've got about 70% of people self-serving. So we're active in 5 of the health boards out of 14 in Scotland, and with another 5 moving towards adoption over the autumn. So probably by January, February next year, we'll have most of Scotland doing it this way. Contact tracing. So the NNS, the National Notification Service, automatically creates the index cases and creates patient records entries for each person based on the positive results that come into that National Notification Service. We added supervisor assignment capabilities, and then added web forms that the contact tracers could use to add contacts and settings to index case. So a very simple contact tracing system built very quickly, when up to that point people were using pen, paper, spreadsheets, and so this very much was us. We called it the simple tracing tools. We needed to do this very, very, very quickly, and so we got that up and running in about 3 weeks, and that was used in the first couple of months, during our first peak in the early summer, and off the back of that, we've now evolved that into a more complex and feature-rich contact tracing service. COVID community co-management. So that's the self-service contact tracing piece. And as I said, this is saying your positive test result carries that self-service form. And we've done a lot of user research with end users around the level of detail that they're prepared to go into. The epidemiologists and contact tracing people wanted 33 questions, and our user design and user interface specialists wanted 3 questions. So we there's a kind of a compromise required to try and get as many people to actually complete it as possible, to understand what is the absolute critical information. At the moment, that critical information is understanding if the index case or a contact is in a healthcare setting, is in an educational setting, or has any significant risk factor, other significant risk factors. So it's really just trying to surface that critical information so that we can prioritize contact tracing as pressure builds. Yeah, and that was developed again early summer, but we didn't put it into practice over the summer because the numbers were low and it wasn't necessary. But we're now about to put that live in November in Scotland. So not quite there yet, but we will be soon. And I guess the last piece is the clinical assessment tool. So this was that SBAR, the structured data collection tool that we deployed. So we did this as a web app, accessible on any device. We actually built it using the Scottish clinical education platform, because 2/3 of our clinicians already used it for CPD, for training. So we didn't have to onboard them into a new system. We didn't have to get them to sign up for new accounts and verify their identity and all that sort of stuff. So we took the path of least resistance and said, right, well, most of our country's clinicians are already using this system. We'll just piggyback on that for this assessment tool. And what that allowed is our assessment centres to very quickly establish themselves, because effectively they didn't have to bring legacy IT systems into line. We could just give them something on their phone in their pocket that would allow them to get going really quickly. And if a student nurse had to get moved in to fill a gap, then that person could be set up in minutes, and off they go. And again, developed very quickly. And we're now talking about we've had 5,000 assessments done in Glasgow, and we're now starting to roll out across the country. So last slide, just a very quick kind of summary, I guess, from us. The biggest take homes here were not necessarily about the content of what we did, but they were about how the right innovation environment, the right methods, the right networks, and an open and flexible infrastructure, digital infrastructure that allows you to quickly prototype, develop, integrate, can make things happen very quickly. And so for the national test result communication system, we did that from idea to design, prototyping, full development, integration of all the relevant systems, governance, so information governance, data protection, clinical safety, quality impact assessment, et cetera, and then put it into practice across the whole country in 51 days. And then for contact tracing, same deal, from bright idea, from a twinkle in someone's eye, to fully deployed across the entire country and in active use in 41 days. And for me, that's the legacy from this, is proving that with the right environment and the right methods and the right infrastructure and the right networks, you can build a fully realized digital co-management service and roll it out across your country, albeit Scotland's 5 million people, but you can roll out across a small country in 41 days. And that's me.